Namaste, I am Dr. Vijayashree Raghavan, Professor, Head of Pathology Department, Chettinad Hospital and Research Institute, and I will be talking to you about the pathophysiology of myocardial ischemia and injury. So, the objectives of my topic are definition of ischemic heart disease, determinants and physiology of coronary blood flow, pathophysiology of IHD, that is ischemic heart disease, etiopathogenesis of the ischemic heart disease, atherosclerosis and its changes, effects of myocardial ischemia and non-ischemic myocardial injury. So, before we go on to the actual subject, let us first see how the word ischemia was derived. It comes from the Greek word ischem, which is to restrain in English, and haima means blood. So, ischemia occurs when the blood supply to a tissue is inadequate to meet the tissue's metabolic demands. Ischemic heart disease is a condition in which there is an inadequate supply of blood and oxygen to a portion of myocardium. It typically occurs when there is an imbalance between myocardial oxygen supply and demand. So, before going to the etiopathogenesis and the pathophysiology of ischemic heart disease, we need to know certain important features of coronary blood flow which are very unique to only coronary circulation. Coronary blood flow is largely regulated by the need of the cardiac muscle for oxygen. And under normal resting conditions, the heart extracts about 70% of oxygen in the blood. As there is little O2 reserve, the coronary arteries must increase their flow to meet the metabolic needs of the myocardium. And it is seen that coronary blood flow is about 225 ml per minute, or it roughly represents about 4% to 5% of the total cardiac output. Now, there are certain points to know about the determinants of coronary blood flow. There are two major determinants of coronary blood flow. One is the metabolic activity of the heart itself, and second is the endothelial cell products which are produced in the circulation. The metabolic activity of the heart, the metabolites released from working myocardial cells. We all know myocardial cells work 24/7. So, the metabolites coming from these working myocardial cells, that is the potassium ions, the lactic acid, the carbon dioxide and adenosine, all these act as mediators for vasodilation that accompanies increased cardiac work. Of these, adenosine appears to be a critical mediator for local blood flow. This we must remember when there is actually a reduction in coronary blood flow. And coming to endothelial cell products, vasodilators like nitric oxide, prostacyclin and endothelium derived hyperpolarizing factor, what is called EDHF. Of these, the nitric oxide is the most important one, and most of the other vasodilators also exert their action through nitric oxide. So, these endothelial cells also release a very powerful vasoconstrictor called endothelin. All these cell products are important when there is a reduction or increase in the coronary blood circulation. And blood flow in the coronary vessel is actually influenced by three major events happening within the cardiac muscle. One is the aortic pressure, the second is the autoregulatory mechanisms, and third is compression of these intramyocardial vessels by the contracting heart muscle, which is very unique only to heart. So, coming to the aortic pressure, as we all know, the two main coronary arteries, that is the right coronary artery and the left coronary artery, arise in the sinuses behind the two cusps of the aortic valve. During systole, when the aortic valve is open, the velocity of blood flow and the position of the valve cusp cause the blood to move rapidly past the coronary artery inlets. Whereas during diastole, when the aortic valve is closed, the blood flow and the aortic pressure are transmitted directly into coronary arteries. Coming to the second important influence, that is autoregulation of coronary blood flow, which is also unique to coronary circulation. Oxygen delivery during periods of increased metabolic demand depends on the auto-regulated change in the vessel tone and in the diameter. So, we have already seen the endothelial cell products and the metabolites which are released during the working cardiac muscle and also in the circulation by the endothelial cells. So, when there is an increased metabolic demand, vasodilation produces an increase in blood flow. During decreased demand, vasoconstriction or return of the vessel tone to normal produces a reduction in the flow. These tonal changes result from vasoactive mediators released from the myocardial cells and the endothelium, which we already saw in the last slide. Here we have the myocardial blood flow and the endothelial cell, and release of these vasoactive mediators. One is the vasoconstricting factor which comes from the endothelial cell called endothelin, and the other vasodilating factors which we already saw, that is the nitric oxide, the carbon dioxide, the adenosine which I told you very clearly, the potassium ions, the lactic acid. So these are important mediators which regulate the coronary blood flow either during increased metabolic demand or during decreased demand. Coming to the third influence of the coronary blood flow, that is the coronary resistance. So 75% of the total coronary resistance to flow occurs across three sets of arteries, that is the large epicardial arteries, that is R1, the second is the pre-arteriolar vessels called the R2, and the third is the arteriolar intramyocardial capillary vessels R3. During systole, the contracting cardiac muscle has a squeezing effect on the intramyocardial vessels, that is the R3 vessel, while at the same time producing an increase in the intraventricular pressure that pushes against and compresses these subendocardial vessels. As a result, the blood flow to the subendocardial muscle is greatest during diastole. This one must remember while knowing about the ischemic heart disease. Now, coming to what is that which produces ischemia in the cardiac muscle? We should know that an imbalance in the myocardial oxygen supply and demand can result in myocardial ischemia and its related consequences. Oxygen supply is determined by the coronary arteries, the capillary inflow and the ability of the hemoglobin to transport and deliver oxygen to the heart muscle. As you see here, the myocardial O2 supply depends on the coronary vessel patency, the ventricular wall compression, the diastolic filling time, whereas the myocardial O2 demand, what we call as MvO2, is determined by the three important factors. One is the heart rate, the second is LV contractility, and systolic pressure, or what is called myocardial wall stress or tension. These factors together maintain the myocardial O2 balance. So, depending on which is dominant, the ischemia sets in. Coming to the most important thing, the heart rate, the influence of heart rate and oxygen demand. Heart rate is the most important factor in myocardial O2 demand for two important reasons. One is that as the heart rate increases, the myocardial oxygen consumption or demand also increases, and the subendocardial coronary blood flow is reduced because of the decreased diastolic filling time with increased heart rate. So, these 2 points we must remember before understanding the pathophysiology of ischemic heart disease. As diastole becomes shortened when the heart rate increases, the myocardial flow can be greatly reduced during sustained periods of tachycardia. Second important factor one must remember is the myocardial contractility and O2 demand. Myocardial contractility is the intrinsic ability of the heart muscle to shorten and generate force. And this myocardial contractility reflects the interaction between the calcium ions and the contractile protein, which you must have seen in the physiology of the cardiac muscle, or the action potential, that is the actin and the myosin proteins of the muscle fibers. So, with increased myocardial contractility, the rate of change in the wall stress is increased, which in turn increases myocardial oxygen uptake. So, the demand is increased now. So, the factors that increase contractility are exercise, sympathetic nervous system stimulation, and the inotropic agents which we use. All these increases the myocardial oxygen demand. Coming to the third point, the LV wall stress, that is the left ventricular wall stress and the oxygen demand. We all know that left ventricular wall stress is the average tension that individual muscle fibers must generate to contract effectively against developed intraventricular pressure. It is proportional to the product of the intraventricular pressure and ventricle radius divided by the thickness of the ventricle wall. So, at a given pressure, the wall stress is increased by an increase in the radius of the ventricle, that is ventricular dilation, what is called preload, and by a decrease in the wall thickness. So, what is afterload? Afterload is the load against which the heart must contract to eject blood. So, an increase in the wall stress either as preload or afterload increases the myocardial oxygen demand. Now, we have already seen the points which favor increased myocardial oxygen demand. Now, what are those factors which reduces coronary blood flow to induce ischemia? So, there are 5 important factors which reduce coronary blood flow, including decreased aortic diastolic pressure. As we already saw, the coronary blood flow is influenced by aortic pressure. So, decreased aortic diastolic pressure will definitely reduce the coronary blood flow. The second important point here is increased intraventricular pressure and myocardial contraction, just now we saw. And our point of interest today here is coronary artery stenosis. This is a very important factor which directly reduces coronary blood flow, which can be further subdivided into what is called fixed coronary stenosis, where atherosclerosis forms a very important, most of the time it is atherosclerotic plaque which forms a fixed coronary stenosis. Second is an acute plaque change on the atherosclerotic plaque, that is the rupture and the hemorrhage can also produce a reduction in the coronary blood flow. And third is when there is a thrombosis as a complication of the atheromatous plaque can also reduce coronary blood flow. Finally, vasoconstriction also contributes to reduction in the coronary blood flow. And fourth important point in coronary blood flow reduction is aortic valve stenosis and regurgitation and increased right atrial pressure. So, now having known that fixed coronary stenosis, acute plaque change, coronary artery thrombosis and vasoconstriction are major contributing factors towards reduction in coronary blood flow and towards ischemia of the myocardium. So, now let us go, after knowing all these important factors about the dynamics of coronary blood flow and the imbalance between the myocardial oxygen demand and the supply. Now, let us go on to the ischemic heart disease, which is synonymous with coronary artery disease. The term coronary artery disease or ischemic heart disease describes heart disease caused by impaired coronary blood flow. So, this ischemic heart disease is a broad term encompassing several closely related syndromes caused by myocardial ischemia, which is an imbalance between the cardiac blood supply, what is called as perfusion, and myocardial oxygen and nutritional requirements, that is the myocardial metabolic demands of the myocardium. And something which is very unique about cardiac myocyte is that these cardiac myocytes generate energy almost exclusively through mitochondrial oxidative phosphorylation, and hence the cardiac function is strictly dependent upon the continuous flow of oxygenated blood through the coronary arteries. It is seen that in more than 90% of the cases, ischemic heart disease is a consequence of coronary artery disease due to atherosclerosis. Now, coming to the causes of ischemic heart disease, as we already saw in the previous slide, more than 90% of the cases, ischemic heart disease is a consequence of reduced coronary blood flow due to obstructive atherosclerotic vascular disease. Less frequently, ischemic heart disease can also result from increased demand, that is hypertension, or diminished blood volume as seen in hypotension or shock, and diminished oxygenation, example due to pneumonia or congestive heart failure. Also, when there is a diminished oxygen carrying capacity, example due to anemia or carbon monoxide poisoning. There are certain risk factors for coronary artery disease. So, some of the major risk factors here I will be telling you are: one is cigarette smoking, elevated blood pressure, that is hypertension, elevated serum total and low density lipoprotein cholesterol, that is the LDL cholesterol, and also presence of low serum HDL, that is high density lipoprotein cholesterol, diabetes, a very important metabolic condition, and advancing age. So, these are some of the major risk factors for coronary artery disease, out of which individuals with diabetes and metabolic syndrome are at very particularly increased risk for coronary artery disease or ischemic heart disease. So, now coming to the actual etiopathogenesis of ischemic heart disease, which can be divided into three important stems. One, as I already told you, more than 90% it is coronary atherosclerosis. So, it is not merely coronary atherosclerosis all the time producing ischemic heart disease. It is superadded changes within the atherosclerotic plaque, that is, for example, acute changes in plaque as rupture or hemorrhage, and sometimes coronary artery thrombosis superimposed on this atherosclerotic plaque, and local platelet aggregation. All these are considered to be superadded changes which also result in ischemia. Then there are non-atherosclerotic causes in about 10% of the people, where vasospasm, stenosis of coronary ostia, arteritis, which is an inflammation of the artery, embolism and thrombotic diseases, compression, aneurysms, and trauma. These are other non-atherosclerotic causes which can result in ischemic heart disease in less than 10% of individuals. Now, coming to the actual pathogenesis, because we know that in 90% of the cases, atherosclerosis is the cause. So, now let's go on to see about the atherosclerotic pathogenesis leading to ischemic heart disease. As I already told you, ischemic heart disease is a consequence of pre-existing what is called a fixed atherosclerotic occlusion coronary arteries and new superimposed thrombosis or vasospasm on the fixed atherosclerotic plaque. These atherosclerotic narrowing can affect any of the coronary arteries, particularly in the descending order. It is left anterior descending order, what is left anterior descending artery, which is called the LAD. The second is the left circumflex artery, third is the right coronary artery. All these can be in single or in combination. Clinically significant plaques tend to occur with the first several centimeters of the origin of either the LAD, that is the left anterior descending artery, and the left circumflex artery, and almost along the entire length of the right coronary artery. Sometimes the secondary branches are also involved, that is the diagonal branches of left anterior descending artery or the obtuse marginal branches of the left circumflex artery and the posterior descending branch of the right coronary artery. Now, coming to atherosclerosis as such. What is atherosclerosis? As the name suggests, atherosclerosis is a pathologic process by which cholesterol and calcium plaque accumulate within the arterial wall. Over time, the fat and the calcium buildup narrows the artery and blocks the blood flow through it, producing ischemia or ischemic heart disease. Now, atherogenesis, or what is called formation of this atherosclerotic plaque, can be divided into 5 key steps. One is the endothelial dysfunction. So, to start an atherosclerotic plaque, there must be an endothelial dysfunction. And second is, after there is an endothelial dysfunction, there must be formation of lipid layer or what is called fatty streak within the intima of the vessel. As we all know, the vessel wall has 3 important layers, that is the intima, which is the innermost, the second is the media, and third is the tunica adventitia. So, when there is an endothelial dysfunction, the second important key step is formation of a lipid layer or what is called deposition of fat as fatty streak within the intima. Now, the next step is that migration of the leukocytes, that is some of the WBCs and the smooth muscle cell into the vessel wall. That is, from the tunica media, the smooth muscle will migrate into the intima towards the fatty streak or towards the accumulation of the lipid. And also migration of WBCs from the circulation into the intima or into the area of fatty streak. Then the fourth step is that now that there is leukocytes and smooth muscle cells into the area of the fatty streak or the vessel wall, there is foam cell formation. What is this foam cell formation? Foam cells are nothing but macrophages which have imbibed the fat present within the vessel wall. So, these foam cell formation is the major determinant for the atherosclerotic plaque and its consequences. Now, once this foam cell formation occurs along with the smooth muscle migration and the WBC migration, there is now degradation of the extracellular matrix resulting in what is called the fibrosis. So, these are the 5 major steps involved in formation of atherosclerotic plaque. Then, what are the contributive factors towards the pathogenesis of ischemic heart disease after the formation of a atherosclerotic plaque? It has been said that, and it has also been proved that inflammation plays an essential role at all stages of atherosclerosis, right from the inception to the plaque rupture. As we already saw in the previous slide, that migration of leukocytes and some of the endothelial cell products producing endothelial cell dysfunction. These are the initial events of inflammation which starts the formation of atherosclerotic plaque and propagates further. Then second major event is supposed to be the thrombosis. Thrombosis is associated with an eroded or ruptured plaque which triggers the acute coronary syndrome. Even a partial luminal occlusion by a thrombus can cause an infarction of the innermost zone of the myocardium, may not be the entire myocardium, but the innermost layer of the myocardium, producing what is called subendocardial infarct. Sometimes the mural thrombi in a coronary artery can also embolize, and these small emboli can be found in the distal intramyocardial circulation. And as you see, these emboli are going along the distal intramyocardial circulation, there will be associated microinfarcts in the myocardium. Then I already told you vasospasm or vasoconstriction. Vasoconstriction, which is caused by the adrenergic agonist, local platelet and endothelial product, directly compromises the lumen diameter, producing ischemia or reduction in coronary blood flow. So, the 3 major contributive factors here are inflammation, thrombosis, which also embolizes, and vasoconstriction during the formation of atherosclerotic plaque. Now, what are the evidences to say that inflammation is a cause of ischemic heart disease? In physiological conditions, leukocytes are not activated by endothelium. This is normal. Whereas, when there is inflammation, there is a change in the interaction between the endothelium and the leukocytes so severe that it leads to endothelial expression of adhesion molecules that bind to leukocytes, maintaining and enhancing a local inflammatory response. This local inflammation produces proteolytic enzymes, making atherosclerotic cap prone to rupture. And the evidence which says is that there is apparent correlation between inflammatory markers, that is the C-reactive protein, homocysteine, and the susceptibility to develop IHD and worse prognosis. So, these are some of the evidences to say that inflammation plays a major role in development of ischemic heart disease in atherosclerotic diseases. Then there is also called as role of oxidized LDL. I already said increased serum level of low density lipoprotein is a major risk factor. So, it is not merely low density lipoprotein, it is the oxidized low density lipoprotein which has a fundamental role in the entire process of atherogenesis from the plaque formation to plaque destabilization. This OX-LDL, what is called oxidized LDL, induces endothelial dysfunction in the initial stage. Then it stimulates the generation of what is called free radicals, that is the reactive oxygen species, which are known to produce destructive changes within the cell. And this oxidized LDL also inhibits nitric oxide synthesis, so we have lost the vasodilation also, one of the major potent vasodilator. And this oxidized LDL enhances monocyte adhesion to activated endothelial cells, thus propagating inflammation. And it induces vascular smooth muscle cells, what is called the SMCs, for migration and proliferation. So, there is accumulation of atherosclerotic plaque now. And also this oxidized LDL is avidly ingested by the macrophages, as I already told you, resulting in foam cell formation. And oxidized LDL may also induce apoptosis, that is programmed cell death and necrosis of the vascular endothelial cells and also the vascular smooth muscle cells and macrophages. So, these are the changes which are initiated by the oxidized LDL. So, it plays a fundamental role or a very important role in the entire process of atherogenesis. This oxidized LDL increased levels relate to plaque instability with a positive correlation with myocardial ischemic severity. Now, coming to the last point, the role of vasospasm. I told you it is inflammation, the thrombosis and the vasoconstriction and the vasospasm. The vasospasm can be initiated by several factors, that is vasomotor tone at rest, segment epicardial coronary hyperactivity and an organic stenosis. So, we already have an organic stenosis in atherosclerosis. So, this vasospasm appears at the sites of significant atherosclerotic stenosis both in acute and chronic settings. Spasm of these atherosclerotic lesions may provoke myocardial ischemia both in early and advanced stages of disease through activation of what is called a downstream vasospastic effector, which is called as ROCK, that is the Rho associated protein kinase, which increases the expression of inflammation related molecules, also increases the incidence of thrombosis and fibrosis. And this ROCK, which is a novel biomarker, that is Rho associated protein kinase, is probably involved in the pathophysiology of angina pectoris, coronary vasospasm, hypertension and also pulmonary hypertension. So, this is one of a novel biomarker which can be used as a diagnostic marker for ischemic heart disease as well. And coming to role of aging in pathogenesis, I told increased aging is an important risk factor for atherosclerosis. So, this aging is a physiological mechanism and an independent cardiovascular risk factor. Its pathogenetic role is strongly influenced by genetic predisposition and environmental features as well. Aging is responsible for endothelial layer integrity loss, arterial stiffness, loss of vessels elasticity and reduced vascular adaptability to physical forces related to coronary blood flow. So, these are some of the major factors in aging which contributes to increased atherogenesis and also increased ischemic heart disease. It promotes an increased expression of cyclooxygenase, that is COX-1 and 2, thromboxane A2, von Willebrand factor and factor 8, all these promoting aggregation and hypercoagulative state. And inflammation per se response is enhanced with aging. So, aging plays a major role in pathogenesis of ischemic heart disease either with or without atherosclerotic lesion. Now, we need to know something about coronary microvascular dysfunction. Though we know atherosclerotic plaque and non-atherosclerotic diseases can produce ischemia, there is important pathophysiological mechanism within the coronary microvascular dysfunction which is related to ischemia. This coronary microvascular dysfunction, what is called as CMD, represents a common pathophysiological mechanism for type 2 myocardial infarction. We know there are about 4 types of myocardial infarction. So, this CMD, that is the coronary microvascular dysfunction, determines an increase in the flow resistance leading to myocardial ischemia in response to reduced perfusion pressure. The term microvascular angina for those patient population was used for the first time in 1985, referring to ischemia triggered by an altered vasoregulation of the coronary microcirculation. A pre-existing transient or permanent microvascular dysfunction may contribute to the development and prognosis of what is called acute coronary syndrome or ischemic heart disease or otherwise coronary artery disease. Now, coming to diagrammatic representation of how atherosclerotic plaque produces ischemic heart disease. As I already told you, you can see in the right side that this is a normal blood vessel, and inside the normal blood vessel you see it is very clear and the wall is uniform and the thickness of the wall is also uniform. Whereas when there is atherosclerotic plaque, I already told you how atherosclerotic plaque is formed. First, there is what is called an endothelial dysfunction, and second, there is what is called deposition of this lipid or the fatty streak, and then there is migration of leukocytes from the blood circulation, also the smooth muscle cells from the tunica media into the intima where there is fat deposition, and there is what is called as release of proteolytic enzymes, and also there is extracellular matrix degradation producing what is called a atherosclerotic plaque. This is the plaque and there is a cap here. And this plaque, yellow color, is representation of the lipid or the fat which is there, that is the foam cell formation, and these are the smooth muscle cells, the leukocytes and the extracellular matrix which are seen as a cap of the atherosclerotic plaque. And now you see the lumen is slightly reduced, not slightly, it is partly reduced. So, this is a partially blocked blood vessel. So, fixed obstructions that occlude less than 70% of a coronary vessel lumen typically are asymptomatic even with exertion. But lesions that occlude more than 70% of a vessel lumen resulting in critical stenosis causes chest pain on exertion, and this is called as stable angina. As I already told you, the risk factors, these are the steps which we already discussed, and what happens is when there is accumulation of this atherosclerotic plaque, initially there is an expansion of the outer wall to maintain the internal diameter, but once there is a 40% stenosis, the inner diameter begins to narrow, producing occlusion. So, what is this acute plaque change? We saw fixed plaque. Now, let us go on to the complications of this fixed plaque, what is called as acute plaque change. In most patients, there is unstable angina, infarction and sudden cardiac death. These occur because of an abrupt plaque change followed by thrombosis. This is termed as acute coronary syndrome. So, plaques that contain large atheromatous cores, that is the yellow color, the central yellow lipid core, and have thin overlying fibrous caps are more prone for bleeding and rupture, and therefore they are termed as vulnerable plaques. And the adrenergic surge promotes the plaque change. So, a fixed stenosis that occludes 90% or more of a vascular lumen can lead to symptoms even at rest, one of the forms of unstable angina. Whereas I told you in the previous slide, if it is 70% and less, a fixed stenosis will not produce angina even at exertion. Whereas once it crosses to 90%, even at rest, it is going to produce chest pain, and that is called as unstable angina. So, when you look at this diagram, you can see the progression of atheromatous plaque. This is a normal vessel wall, and here you see there is mild deposition of fat which is called as fatty streak. This is a very initial stage. Most of us will be in this stage only when we start developing or aggregating more lipid, and when there is a complication that people go in for angina. So, as age progresses, over time there is a buildup of this fat and also the extracellular matrix along with smooth muscle cells and the Inflammatory cells, most important. All these contribute to a formation of fibrofatty plaque, what is called as an advanced or vulnerable plaque. So, as the core increases, the vulnerability increases. So, you can see here what are the complications of these acute plaque change or advanced vulnerable plaque. One is aneurysm and rupture. You can see that there is a rupture of the vessel here. There is an aneurysmal formation. What is aneurysmal formation? It is a dilatation of the vessel wall. And it can also have superimposed thrombosis like this. You can have a thrombosis because of local platelet aggregation and endothelial products, which promotes thrombogenic mediators and promoting formation of thrombosis. This can embolize and give to further complications. And sometimes what happens, there is entire lumen which is occluded by the plaque, and this is called as critical stenosis. So, all these lead to myocardial infarction and unstable angina. So, this is the vulnerable plaque. So, what are the changes in plaque? As I already mentioned, it can be rupture, ulceration or erosion of the plaques leading to occlusive thrombosis. Hemorrhage into a plaque is another important complication which results from the rupture of the overlying fibrous cap or of the thin-walled neovascularized vessels. And third complication is atheroembolism. This results from the plaque rupture with discharge of atherosclerotic debris into the bloodstream. Now, finally, aneurysm formation. Atheroma-induced pressure bar ischemic atrophy of the media with loss of elastic tissue is the cause for the aneurysmal dilatation of the vessel wall. As I already told you, vulnerable plaques have three important histologic hallmarks compared to a stable plaque. That is, one is the larger lipid core, which is more than 40% of the total lesion area, a very thin fibrous cap, that is 65 to 150 micrometer, and many number of inflammatory cells or the leukocytes, most important. So, what is stabilizing and what is destabilizing? When there is more lipid and inflammatory cells, it is called as destabilizing plaque, where there is increased lipid content and a very thin fibrous cap with large number of inflammatory cells. Whereas, when there is increased smooth muscle cell migration with increased collagen deposition, there is a thick fibrous cap and a less of core material, that is your lipid core, more collagen, leading to stabilization of the plaque. So, when it is stabilization, it is a stable angina and the patient will not have any untoward events. Whereas, when it is destabilizing, individuals can go for changes in the vulnerable plaque leading to unstable angina and myocardial infarction as well. So, knowing all these things, what are the manifestations of ischemic heart disease? Manifestations may include one or more of the following cardiac syndromes, that is angina pectoris, literally called as chest pain, where ischemia induces pain but it is insufficient to cause myocyte death. Whereas, the second important cardiac syndrome is myocardial infarction, where the severity or duration of ischemia is sufficient enough to cause myocyte death. And the third complication is chronic ischemic heart disease with congestive heart failure, where there is progressive cardiac decompensation which occurs after an acute episode of myocardial infarction, or it can be secondary to repeated small ischemic insults to the cardiac myocyte. And finally, you have sudden cardiac death, which is a consequence of myocardial infarction, but most commonly resulting from a lethal arrhythmia without any myocyte necrosis. So far, we have been seeing ischemic injury to the myocardium. Now, let's go on to see about acute non-ischemic myocardial injury, where acute myocardial injury, that is the rise and fall in the biomarkers, mainly the cardiac troponin, in the absence of primary ischemic cause, that is in the absence of myocardial infarction, is the only evidence to say that there is acute non-ischemic myocardial injury. Here also the patients will come with chest pain. Now, what is chronic myocardial injury? Chronic myocardial injury where the cardiac troponin more than 99th percentile without an acute change is termed as chronic myocardial injury. So why is it we should understand this? Because type 2 myocardial infarction may arise in the context of various acute medical and surgical conditions that are similarly associated with non-ischemic myocardial injury, making the differentiation between type 2 myocardial infarction and acute non-ischemic myocardial injury challenging in a very common clinical setting. That is why one must know that there can be an acute non-ischemic and chronic myocardial injury. So this is myocardial injury in the absence of ischemia, which is categorized as acute or chronic non-ischemic myocardial injury. So we have myocardial injury which could be acute or chronic, and this acute could be non-ischemic or ischemic. When it is ischemic, we know it is either a type 1 myocardial infarction or a type 2 myocardial infarction. In type 1 myocardial infarction, it is increased block instability and inflammation. In type 2 myocardial infarction, the triggers demand ischemia, that is the hypertension, microcirculatory dysfunction are the two major triggers which demand ischemia. Coming to acute non-ischemic injury, here the trigger is a direct myocardial toxicity where there is contraction band necrosis without any ischemic changes. And in any chronic injury to myocardium, there is an increased risk of stroke. Also, it perpetuates atherosclerosis, inflammation and fibrosis. So, with all these, I would like to summarize saying that myocardial ischemia is directly dependent on an impairment of the crosstalk between myocardial energy state and coronary blood flow, atherosclerosis being the major etiological factor in more than 90% of the cases. And recently, it is known that coronary macrovascular and microvascular disease may represent just a portion of the multifaceted pathophysiology of myocardial ischemia. My references are mainly from Robbins and Cochran, Pathological Basis of Disease. Thank you for a patient hearing.